Okay, good evening everybody. We're going to do a quiz on pregnancy and congenital heart disease. And so just get ready with your answers. Now, congenital heart disease and pregnancy can occur in 0.4 to 4% of pregnancies, and really whether the pregnancy will be successful and safe depends upon heart is able to raise its stroke volume and if it can tolerate the rise in heart rate. Now, in general, heart disease in pregnancy increases either maternal risk or fetal risk or both. So either mother and fetus can have adverse outcomes. So let me ask you, if you think about cyanotic heart disease and acyanotic heart disease, which one has a worse prognosis? And we're talking about cyanotic heart disease in the mother. So a pink mother or a blue mother, who do you think will have a worse prognosis? Cyanotic or acyanotic in terms of outcome of pregnancy? So everybody says cyanotic. Divyesh, you can just put to everyone so they can all see your answers. And that's right, it is cyanotic. So in fact there was a study that came out in India from Eisenmengers, and they looked at 275 patients from 1980 to 1996. And in cyanotics, they had a still birth of 13.6%, whereas acyanotics it was 0.8%, small for gestation age 36% versus 7%. So you can see that cyanotic mothers had much higher risk of stillbirth and small for gestation age than acyanotic mothers. Okay. Next question. Can you name 5 lesions that are very well tolerated in pregnancy? 5 kind of heart diseases that, you know, if the mother has, you can tell her, okay, don't worry, just go ahead, get pregnant. Give some examples of lesions well tolerated in pregnancy. Okay, ASD, mitral regurg, anything else? Small VSDs or moderate VSDs, right? Not large VSDs. So small to moderate shunt, valve regurgitation, mild to moderate stenosis, that's right. So in general, valve regurgitation is well tolerated. The reason being, in pregnancy, your systemic vascular resistance reduces. So when your systemic vascular resistance reduces, you are able to have actually your afterload reduces and you have better forward flow. So valve regurg is well tolerated. Mild or moderate valve stenosis. Small to moderate left to right shunts without pulmonary hypertension. Remember, with pulmonary hypertension, it will not be very well tolerated. Heart block, yes, I think Divyesh has done the portal, which is good. And post-op heart disease with good function. So there are some like post-op tetralogy, post-op stemming, post-op fontan, where they've got good ventricular function and minimal hypoxia. They actually can do quite well in pregnancy. Of course, in a fontan, you have a volume load on that single ventricle. And similarly, in a stemming, you have a load on that right ventricle. But in general, as long as they have good ventricular function, minimal hypoxia, so a patient who's had set repair in childhood, they can very well go ahead and get pregnant. So the things to remember, well-tolerated lesions are valve regurgitation. This can be AR, this can be MR, as well as up to moderate stenosis or up to moderate shunts. Now name some heart diseases which are at particular risk in pregnancy. So if these women had it, you're worried about them in pregnancy. Can you name a few lesions that are at risk during pregnancy? So Eisenmengers is right, yes. Severe AS or really any left heart obstruction, right? So severe pulmonary hypertension, any left heart obstruction, Marfan, anything else? Remember, any aortic root or aortic aneurysm. So for instance, a patient who has had a fat aortoplasty of the coarse and they get an aneurysm, they are at risk of rupturing during pregnancy. Okay, so left side obstructive lesions. So talk with severe PS, yes, because they will fall into the category of a very cyanotic patient, and in general that kind of patient you're going to ask them to get corrected and do it. So yes, any very blue patient would be at high risk. Pulmonary hypertension, cyanotic heart disease. So any cyanotic heart disease is at high risk, whether it's TOF with severe PS whether it's a single ventricle with severe PS, any cyanotic heart disease is at risk, any pulmonary hypertension, whether it's a large VSD Eisenmenger, whether it's PPHN, pulmonary hypertension is at risk. Similarly, any left-sided obstructive lesion, whether it's severe AS, tight coarctation, severe mitral stenosis. Why are they at high risk? Because they are unable to increase their cardiac output as time goes on. This is one more to remember, poor ventricular function. These patients are at higher risk in pregnancy, and the reason is the ventricles are not able to pump very well already, and you add a volume load onto that heart and you get into trouble. So poor ventricular function, especially ejection fraction less than 20%, very high risk, and potentially fragile aorta. So this can include Marfan's, this can include things like your Ehlers-Danlos, tortuous arterials, any of those, or aneurysms of the aorta, anywhere where you, again with the increase in volume you have a risk of rupture and dissection. Okay, and now the last one is the prosthetic valve. As you know, they are at risk. One is it's a prothrombotic state. Secondly, you can have the side effects of warfarin, so you may have to manage them with heparin. So you can have valve dysfunction and the problems of treatment. So these are all kind of the higher risk categories for pregnancy. Okay, all clear on this? So we'll go over a few of the lesions and management of these lesions. So an atrial septal defect, right? You can have blood loss. So you already have a left to right shunt. Now you have blood loss. So you have LV and coronary flow goes down. Second is you have a volume load on that dilated right atrium, right ventricle, you can have arrhythmias. And third is you've got a risk of paradoxical embolus. So these are the risks of an ASD in pregnancy. Now cyanotic heart disease. So when you look at an ASD, there are all these risks, but there's not too much you can do apart from making sure they don't have blood loss, treating their arrhythmia and so on. Now let's look at, on the other hand, a patient who has a cyanotic heart disease. Do you think his outcome will be worse for the mother or for the fetus? Which one is worse in cyanotic heart disease? Is the mother likely to die or the baby likely to have problems? Fetal. All agree with that? All agree. Yeah? As we saw in the earlier study from CGI, what does happen is that you have small for gestational age and you have early stillbirth. So you have an increased risk of miscarriage, prematurity, small for days. And the woman will usually survive. Commonest, of course, lesion would be tetralogy. So in cyanotic heart disease, it's the fetus that gets affected. And therefore you advise the woman to have her surgery, get acyanotic and then get pregnant. Now, if the O2 stat is less than 85%, the risk of fetal death is very high. Almost 50%, and this you have to use when you're counseling the parents. That if O2 stat less than 85%, risk of fetal death is very high. So ideally they need to avoid pregnancy. So what is going to be your treatment? If you have a woman with cyanotic heart disease, now she's gotten pregnant, what is your treatment? What are the things you will suggest to her during pregnancy? What would you suggest? Okay, you could advise MTC if she was early. What else? You could make sure that she's not too polycythemic. You could replace her iron. You can make sure she's well hydrated. Yes. So those are all. You could give her oxygen. So one thing you're going to advise is make sure she has bed rest, because she already has a demand on her heart and that demand has increased. She already has risk of a small baby, so she needs to rest. So these women need to rest. You can also give them home oxygen, so that helps with some amount of oxygenation. Remember, when they get admitted to your hospital, they need IV filters, because otherwise they are at risk for right to left shunting. Any air in the IV line goes right to left and goes straight up to the brain. So you need to keep the hematocrit lower, avoid iron deficiency. You can, in some of them, if they have a tendency to thrombosis, give them heparin, not in all patients. And there is an argument. Some people argue that you should do a cesarean section, but this is controversial. So one argument is that when you do a vaginal delivery, there's that strain, you have more right to left shunting, and you can actually have fetal hypoxia. So you could argue that they should have elective cesarean sections. and keep blood ready. Remember, they're not going to do very well if they have acute blood loss, coronary perfusion gets affected, they already have oxygen carrying capacity issues. You need to avoid hypovolemia, make sure they're not dehydrated, and keep the blood ready at delivery. After they deliver, early ambulation, support force so that they don't get DVT and they don't get, because if they get a DVT, again it can go right to left. That is a big danger. Okay, so this is your general treatment of cyanotic heart disease in pregnancy. Okay. Now, next question for you, left heart obstruction. Say you have left heart obstruction. What happens to the Doppler gradient in pregnancy? Does it go up? Does it go down? Everyone says it increases. So that is true. In general, it will increase. When can it go down? Can it go down in pregnancy? So do you have a Doppler gradient, say in aortic stenosis, that reduces over time? In which situation does that happen? When you have LV dysfunction, right? Yes, that's right. So in general, what will happen to your Doppler gradient will depend upon how the patient was before pregnancy. So if they were asymptomatic, if they have good LV function and they had normal exercise, they tolerate pregnancy very, very well. And because of that increased volume load, cardiac output, so on, Doppler gradient actually increases. On the other hand, because in pregnancy the systemic resistance is low, but they are unable to increase their stroke volume, cardiac output, they try to increase their stroke volume by tachycardia, then it affects their coronary filling, then they have ischemia, and then they get LV failure, then actually that is an LV that is not coping, and the echo Doppler gradient will decrease. This patient will present with tachycardia, tachypnea, and chest pain, angina. Okay, so if you see that the gradient was say 50 and now gradient has gone up to 80, it doesn't mean she needs a ballooning. It means she's tolerating her pregnancy quite well and she can be followed. It's only an issue if you start seeing that there is LV dysfunction. That means that LV is not coping, and you will actually find that the echo Doppler gradient decreases. Okay, all clear on this concept? Now treatment. Say a woman, okay, happens to get pregnant, she's got left heart obstruction. What is your treatment option? What will you advise her? Any advice? Okay, BMV is severe MS, so it's always, of course, doing procedures during pregnancy. You have to think, really hard whether she really needs it. If she's very symptomatic, you take the risk, right? Because if they are symptomatic, you are going to intervene. But what are the other things you can do before doing a cath procedure or surgical procedure during pregnancy? Any medical options? Could you ask her, like, for instance, again, bed rest? Right? So remember, first you try your medical thing. So again, they have left heart obstruction, they're unable to increase their cardiac output. First thing you want to tell them is take it easy. Lie down, watch movies, take bed rest, right? Because that will reduce your demand on your heart, and therefore bed rest is a pretty good thing for a pregnant woman. She can of course walk around and so on, but not do over aggressive, going to the gym every day and so on. The other thing you can consider is beta blockers, because it increases your diastolic time, especially in mitral stenosis, so you can have time for LV filling. And try and continue until fetus is viable. If they are very symptomatic, you can do a valvotomy, either balloon, ideally balloon earlier. But before that, you're going to try bed rest. If possible, in MS, give beta blockers and try and discontinue through till the baby is viable and then deliver early. Okay. Now, Eisenmengers syndrome, and a woman gets pregnant. Can you tell me what do you expect is the percentage of mortality? What are the chances that she will die during this? So you say, Venu says 60%. Anyone else? Any number? Chance of maternal mortality. And what is the cause? Why do they die? Why do they die? From what? What is the cause of mortality? So one could be arrhythmia. What else? Hypercoagulation. Right to left shunting. What else? RV failure, right? Because they've got a fixed pulmonary hypertension, they're not able to get blood out there, they can have RV failure, they can have low cardiac output. So mortality is 50% despite optimal management, and they can die of ventricular failure, right to left shunting and hypoxemia, they can have emboli, they can have arrhythmias. So they can die from a wide variety of things, but overall mortality, you need to know this number, 50% in Eisenmengers, because this is what you will use to counsel patients who have Eisenmengers, who want to get pregnant, and you will strongly counsel them to do what? To adopt. You know, this is one situation where you will say, look, there's a 50% chance you will die, you need to adopt. That's a very good option, and that's kind of the way we need to push them in our counseling. Now, advice, if they're pre-pregnant, ideally you should have them undergo sterilization so they can't accidentally get pregnant. The first trimester, medical termination. If for whatever reason, and I've had one of these patients, they refused to terminate and insisted on getting pregnant, then as soon as the resting saturation falls, somewhere in the second trimester, you need to admit them so that they can be on bed rest, they can be taking oxygen, because oxygen will, have some effect on their pulmonary resistance, and just keep them in the hospital. If they have an arrhythmia, it can be treated. If they have a right to left shunt, we're giving them oxygen. So if they insist on going on, the best chance of salvaging them is to make sure they're in a, they're bored, but they're sitting in the ward on oxygen, on rest, and being monitored. Okay, all clear on this? Now, treatment, oops, I gave you the answers already, but again, bed rest. So if you see a lot of congenital heart disease in pregnancy, when you're asked what do you advise them, you need to start with bed rest, with rest. So in Eisenmengers especially, again, when you rest, it decreases your right to left shunt, so somewhat you can maximize fetal growth. You need to give them oxygen. Sometimes you can also give them prophylactic heparin, especially because they're at risk for thrombi and emboli. So if they're quite hypercoagulable, then prophylactic heparin is not a bad option. And cesarean section is considered very safe. So you need to promptly replace blood loss to a quick in and out of the baby. Okay, now let me ask you this question. If you had a large VSD, you had pulmonary hypertension, you close the VSD, patient still has pulmonary hypertension. What is the prognosis now when she gets pregnant? We said in Eisenmengers syndrome, the maternal mortality rate was 50%. In pulmonary hypertension, after post-operatively, or let us say in pulmonary hypertension, PPHN. So which one has the worst prognosis, fetus or mother? Mother, all agree mother, right? And just remember, in this case, is the opposite of your cyanotic. In cyanotic, we said that it's the fetal growth that gets affected. They can have small for gestation age, they can have stillbirth. Here, these patients are not blue, they are pink. They are acyanotic, so fetal growth is unaffected, and that's right, maternal risk is very high. So again, these are women that you're going to advise not to get pregnant and rather to adopt. If they do get pregnant, again MTP. Now in this case, admitting them and giving oxygen you can do, but already they are acyanotic. The only thing that oxygen will do is it may help you a little bit with your pulmonary vascular resistance. So maternal risk is still very high, and same treatment is Eisenmengers. The difference between Eisenmengers and this is what? What is the difference between Eisenmengers and pulmonary hypertension after VSD closure in terms of outcomes? Well, in both of them they have the high maternal risk. Yes, the difference is in your fetal outcome. If you see in pulmonary hypertension after VSD closure, fetal growth is only normal. But in Eisenmengers they are blue, so they are cyanotic. So you're going to have also, apart from maternal risk, you have a risk of fetal issues. And that's one of the reasons we said, keep them on rest, to give them oxygen and help with a bit of the fetal growth. In this pulmonary hypertension, they don't have so much, there's no really fetal risk. but the maternal risk is still very high. So the difference between the two is only in terms of the fetus. Treatment-wise, it's the same. Try to do MTP early sterilization pre-pregnancy, MTP first trimester. Can't do, in this case, they're not going to admit when stats fall because saturations are not going to fall. They're just going to admit in second trimester, before the end of second trimester, and basically have them rest and have oxygen and hope for the best. I don't know about the use of sildenafil in this situation in pregnant women. I would imagine it's not such a bad idea. If anyone has any studies on that, just let me know. Now that we have those medications, whether to just help with pulmonary resistance during pregnancy. Okay, name some lesions where you have fragile aortas, and what is the treatment you would recommend? What are your recommendations during pregnancy? So we talked about all the categories which have high risk in pregnancy: cyanotic heart disease, Eisenmengers and pulmonary hypertension, fragile aorta. So Marfan's is one. What is the treatment you would recommend? Treatment recommended. Okay, Marfan's, Ehlers-Danlos, also things like patch aortoplasty post coarctation repair, right? Who have aneurysms. So beta blockers. Okay, any other treatment? Greater than 4 centimeter surgery. Ideally, that should be planned before they get pregnant. That's not something you're going to do during pregnancy. Once they get pregnant, putting on them on open heart and so on, your fetal demise rate will be very high. So again, so coarctation even after surgery is a fragile aorta in the sense that it has an increased risk of dissection or rupture. So yes, you need to avoid strenuous activity. See, because one of the things, like we advise patients who have, let's say, have had coarctation and they have hypertension, or they have had coarctation repair, you don't recommend to them that they go to the gym and really pump iron, right? Because that's a load, and that's a load on the aorta. So they need to avoid, they can do normal activities, but they need to avoid very heavy weightlifting and so on. So rest again. So you see the theme in your exam. What do you want to do with this heart disease and pregnancy? First thing you say REST. You won't go wrong. So before you recommend surgery and medication, start with rest. You can't go wrong with that, because in all these patients you want them to basically take it easy to avoid that kind of load on the heart, to avoid them increasing their cardiac output. So rest. In addition to rest, whenever you've got a aorta which is prone for dissection, you've got to avoid heavy weights. So this you have to remember. So avoid heavy weights, number 2. Third is you can give beta blockers throughout pregnancy. Quite safe. You need to push, delivery, of course, look at the glucose of the baby and so on, but beta blockers can be used. And remember, shorten the second stage. So in labor, you don't want them straining. See, we're talking about avoiding heavy weights. You don't want that afterload on the aorta. So they shouldn't strain. You should, do a very short second stage, help them with forceps or vacuum or something to expedite delivery, so that you avoid too much of a strain on that aorta. Okay, all clear on that? So, question for you. Cardiac surgery during pregnancy, can it be done? Yes? No? We said BMD can be done, right? So everybody says yes. Cardiac surgery, all agree? And yes, the answer is it can be done. And it's been performed for PDAs, for coarctation, for tetralogy of Fallot, for mitral stenosis, for aortic stenosis. It has been performed during pregnancy, but of course patient needs to buy it. In the sense, patient really needs to deserve it, because the mortality is very high. So that's why when you are asked the question, this patient has severe aortic stenosis and is pregnant, what are you going to do? First answer is not going to be, I'm going to go in and do a valvotomy. First answer will be, I will rest, I will do this, I will correct anemia, I will watch. If the patient is, you're not able to hear me, Priyesh? Anyone else can't hear? So mortality is high, and therefore it has to be avoided unless the condition is life-threatening. Okay? 20% mortality just from the bypass alone. Okay, contraception in heart disease. Which method would you recommend? So barrier is one. Okay, any other? All say barrier. Okay. Anything else apart from barrier? So IUCD. IUCD is not a great option because they can have infections and so on. Okay. Sterilization, yes, as we said for Eisenmengers or pulmonary hypertension. So what is no is actually estrogen because there's a risk of thrombosis, and actually IUD also there's a risk of infection. And they are, as you know, at risk for endocarditis. Also, some of them may have issues anyway with bleeding and so on. So IUD is probably not a good idea. What is a good idea is barrier method and also progesterone pills or the progesterone injection. You don't have the issue of thrombosis with that. So just remember, barrier method of course you know, but the other one if you do want to use an injectable would be progesterone. Okay, estrogen definitely to be avoided because they are already hypercoagulable. They have a risk of thrombosis, embolism and so on. So contraception in heart disease, barrier method or progesterone. Now, who would you recommend therapeutic abortion for? In which kind of patients? One, we said patients with Eisenmengers, patients with pulmonary hypertension. Who else? If you saw them first trimester, you would say, you know, I really feel before 20 weeks you need to have an abortion. LV dysfunction, that's right. As we said, very blue patients and LV dysfunction, especially if the ejection fraction is less than 20%. So, mothers with Eisenmengers, maternal age less than 20 and 35 is not an indication for therapeutic abortion for women with heart disease, right? Unplanned, no, I'm talking about therapeutic abortion women with which type of heart disease. Unplanned pregnancy, that's of course their own call. But in which type of heart disease? So the type of heart disease would be either Eisenmengers or patients who have class 3 or class 4 symptoms. Because when they're very symptomatic, you know, either you're going to have to try and do surgery during, which has a high mortality. So it's better to have a therapeutic abortion, then when they are in a non-pregnant stage to go in and have their surgery. So CHF class 3 or 4, angina, interestingly, and these are the guidelines for therapeutic abortion in pregnancy and heart disease. So patients who have angina, it suggests that their coronary perfusion is compromised. Whether it's left heart obstruction, whether it's because they're having, you know, pulmonary hypertension, not enough cardiac output, not enough whatever, any patient having angina, prognosis is quite poor. Severe LV dysfunction, again therapeutic abortion is recommended because an LV which is not functioning does not do very well when it's volume loaded. And Marfan with an aortic load greater than 4. So these indications you need to remember. Like patients with heart disease who get pregnant, therapeutic abortion, this would be your class 1 indication. No one will argue with you. They may argue with you if you take a patient with a moderate VSD and make them have, or if you take a patient with an ALD and say go have an abortion. But in these categories, Eisenmengers or any pulmonary, severe pulmonary hypertension, heart failure class 3 or 4, severe LV dysfunction, and a very dilated Marfan's route. There's no argument. I think everyone would agree that these patients should and undergo therapeutic abortion. Okay. Now, what mode of delivery? You have a woman with heart disease. She's pregnant. She's gone to term. What do you want to plan in terms of her mode of delivery? What are the indications for cesarean section? Which woman would you say, look, you need to have elective cesarean section? Okay, so if you're doing vaginal, you want to cut short second, that's right. So everyone says left LV outflow, you want to do cesarean. Anything else for cesarean? Any other indication? So for all women, you are going to recommend vaginal delivery with second stage shortening. Indications for cesarean are again really the same indications that you wanted to tell them go and have an abortion. One is again heart failure, significant left heart obstruction, Marfan's with aortic root. So when we talk about heart failure, this would also include an LV that's dysfunctional. Severe left heart obstruction is another, because when they push, they have problems because you've got all that afterload on that heart. They're not able to increase their cardiac output. Right to left shunt if there's fetal distress. So if the patient is blue and now you have fetal distress, cesarean section. And again, Marfan, anyone with a fragile aorta, it's better that they don't be pushing and they don't have afterload on that aorta and they have an elective cesarean section. So answer for you when you ask what mode of delivery in women with heart disease who are pregnant, answer will be we aim for vaginal delivery with second stage shortening, but cesarean section is indicated in women who have heart failure, who have fetal distress with cyanosis, who have dilated aortic roots, or who have significant left heart obstruction, especially if they're having angina or other symptoms. Okay, all clear on this one? And I think I'm coming to the last few. Genetic counseling. Mother has heart disease, she's now pregnant. What are you going to tell her about what are the chances that her baby will have heart disease? Mother with heart disease, what are the chances her baby will have heart disease? Okay, so you're going to tell her about fetal and maternal risk. As we discussed, if she's blue, you're going to tell her that there is a high risk of small for gestational age or stillbirth. If she's pink, you're going to tell her she has a risk. Yes, and the answer, and you're also going to tell her that there is a chance the baby will have, and it ranges. Actually, it depends. There are certain lesions that have a genetic predisposition. Now let me ask you, what is the incidence of heart disease in pediatrics? Overall incidence roughly. 1%, 5%, 10%. 9 out of 1,000, which is roughly how much? 1%, right? So normal risk of heart disease is 1%. If you have heart disease in one of the parents, so in the mother, the chance in the baby is 2 to 4%. Now there are certain maternal lesions. So when you say 5% or 10%, there are certain lesions that do have that. So this was a study by Nora, old classical study. For instance, left heart obstruction, AS, 13 to 18% recurrence if the mother had it. VSD somewhere 6 to 10%. Pulmonary stenosis 4 to 6. Petrology 2.5. So roughly, if you've got your normal risk of heart disease is 1%. The chance of heart disease in the next kid is 2%. If a mother has or a father has heart disease, the chance of heart disease in the baby is roughly 3 to 4%. It's 2 to 4%, but it's transmitted more strongly to the mother. So if the mother has, chances are around 3 to 4%. But that still means 96 to 97% she can have a normal baby. So it is better to say, look, you have a good chance of a normal baby. Of course, the maternal and fetal risks are there. And yes, you need to advise them to get a fetal echo. By what month should you get a fetal echo? Oops, I gave you the answer, 16 to 18 weeks. And the reason is you can do it up to 20 weeks. But in India, the termination can occur, legal termination by 20 weeks. It's better to advise 16 to 18 weeks. Because if there is something, it gives them 1 or 2 weeks to decide and to plan. They're not rushing around at the last day to have a legal termination. So generally we advise fetal echo somewhere between 16 to 18 weeks of pregnancy if the mother has heart disease, so that we look for that recurrence in the fetus. Okay, and I shall end with that. I think women with heart disease is a challenge, and really you need the OB involved, the cardiologist, your anesthetist, a good labor room, a good neonatal unit, and everybody involved for the care of these patients. Okay, thank you very much. Any questions?